Yeah. Okay. Hello, 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 hello. I feel weird not in my scrubs. This is crazy. Hello, everybody. We are here with Morghan. She loves this part. And we are talking today about breast health still, as well as breast cancer, kind of where you go after the diagnosis.
Yeah.
And anything else.
Yeah, and how it impacts women on a daily basis once they receive a diagnosis of breast cancer.
So if anyone out there has questions or anything like that, don't hesitate, type them up, put them in there.
Hi, Heather.
And otherwise, we are going to get started. So with that being said, we have women who come in, get a breast exam. A lump is found. They want it biopsied, or we recommend they get it biopsied. We send them then to a surgeon who then tells them, oh, the pathology is not so great. Unfortunately, you have breast cancer, so they send them to an oncologist.
That's bad news, and news that nobody ever wants to hear. And I think anytime that anybody has a lump is what they're holding their breath, hoping they won't hear. So I think it's very distressing just to get the news. But then they'll go on to either, depending on where they live, they may not see an oncologist first and foremost. They may have a procedure done by a general surgeon. So depending on what they need, the first step is probably determining the type of cancer that they have, because that's going to change the treatment mechanism. So sometimes the initial treatment is surgical, and sometimes the initial treatment is non-surgical.
Sorry, I'm apparently commenting. I'm assuming they can hear us though, so that's great. Sorry, carry on. Keep going.
Sometimes the initial treatment is surgical and sometimes it's non-surgical. In either case, though, it's going to have a pretty profound impact on the woman's life. So whether she has surgical intervention or whether she has an intervention that doesn't initially involve a surgical procedure, she's going to have her life impacted. And it's going to be impacted not just in the treatment that she's receiving, but in her perception of herself.
Correct. And I know we've come across a couple of women who have come in, and their mentality about who they are as a woman is very different, and we can cover that in a bit. But when you talk about breast cancer, and there's an array of types of breast cancers. I mean, there's multiple different kinds. So when you're talking about maybe a patient doesn't necessarily have to go to see an oncologist, that can kind of be for different reasons. Maybe
they live rurally, maybe they don't have access to an oncologist, maybe it's something that can be managed by a general surgeon initially if they're going to have surgery initially, without waiting to go to the oncologist. Kind of depends on somebody's presentation and what it is that's been diagnosed with the pathology. So when they have that initial biopsy and they receive the diagnosis based on the cells that are cancerous, that's going to help kind of direct the treatment that they receive. And yes, ideally you would have an oncologist treating somebody, but there are some rural areas where that's harder to access, or for some people with different kinds of health insurance, that's also a harder thing to access.
Which is a bummer. That's a bummer. A lot of times when a woman is diagnosed with breast cancer, and maybe I'm misspeaking, but a lot of times that from what I understand, they are then, it is recommended that they maybe get a hysterectomy as well.
Yeah, that kind of depends on the age of the woman. So if the woman's under the age of 40 and she's diagnosed with breast cancer, that's highly likely to be a hormone dependent and hormone receptor responsive cancer. So that's something that's stimulated by the production of estrogen, and it increases the likelihood that she would develop ovarian cancer over the course of her lifetime. So once she's done with childbearing, it really is in her interest to have a complete hysterectomy. And a hysterectomy we think of as removal of the uterus, but in that case, they would want to remove the ovaries as well, which has huge implications because it puts the woman into what's called surgical menopause. And somebody who's under the age of 40 having a total hysterectomy, including the removal of her ovaries, is going to have huge impacts in her life because she's now going to be going through menopause as a young woman, and that's going to impact a lot of things.
Yeah.
From her mood to her sleep to her interaction with her significant other to how her body feels on a daily basis.
Women who get breast cancer at a younger age, who are still in their childbearing ages, where maybe they still want to have children, what would be kind of the, and I don't want to say likelihood because I know every case is different, but maybe statistically, I don't really know the right way to ask this, but a woman who has breast cancer or had breast cancer and still wants to have kids and saying, I, want to, and maybe it's recommended that they get a hysterectomy and they want to hold off on that because they would still like to have kids or have more kids or be a surrogate or whatever it may be. I mean, I don't know if that's possible, but whatever it may be, what's kind of the pros and cons there? Or
so, I mean, now there are, for women who are younger who are diagnosed with breast cancer, now there are some fertility sparing treatments that will potentially allow women to go ahead and get pregnant afterwards. It kind of depends on the particular kind of cancer and how aggressive it is. So it's called staging. They need to do staging and figure out how far advanced the cancer is and how aggressive they have to be with the treatment. However, if somebody's receiving chemo or significant radiation, the likelihood that that's going to render her infertile, regardless of whether she keeps her ovaries and regardless of what's going on hormonally for her, is pretty high. So generally what will be recommended is a harvesting and storing or cryopreservation of those eggs prior to the initiation of treatment, just because we know that chemotherapy is very toxic and it's going to impact the quality of the eggs, even if she comes out the other side being able to ovulate and being able to not have to be on suppressive therapies that reduce the likelihood hormonally that she would be able to get pregnant. Now, best case scenario, somebody does cryopreservation and is able to get pregnant with those eggs, she does have an increased risk if she has an estrogen receptor dependent cancer. She does have an increased risk of recurrence, and not just recurrence in the breast. So I think sometimes we think of breast cancer as being really limited to the breast, but about 33% of women who are diagnosed with a primary breast cancer go on to have metastatic disease. So I think sometimes we think, oh, I'm a breast cancer survivor and the cancer is gone, and then it shows up somewhere else. So one of the things that I know that we had posted an article about a woman who was living with metastatic breast cancer. One of the things that we're really bad at in this country is detecting those metastatic processes and knowing that they're there early and then treating them. We're also pretty bad at helping women understand what they should be looking for as far as metastases. And one of the primary places that breast cancer tends to metastasize is to the brain. So
follow up, like once that is diagnosed, kind of what could a woman's help me out here, her like plan of care to either catch that early or catch any metastases to the brain or anywhere else for that matter, what could treatment plan kind of look like? I'm probably asking this super wrong, so forgive me.
Yeah, so I think I'm going to interpret what you're asking as how do you go about being aware of and detecting the metastasis so that it's treated in that early stage. And I think that that is kind of dependent on your care team. So it's kind of dependent on what kind of particular cancer you have, but also on your care team and how involved they are in ongoing monitoring. Sometimes once you're in remission from breast cancer, there's not really a lot of ongoing management. There's, every 6 months you get a mammogram and you have breast imaging, but we tend to fixate a lot on the breasts themselves and not so much on areas where things could metastasize. And the primary places, like I said, the brain tends to be one of the locations where breast cancer will show up again, and it shows up as a metastatic disease there, but also in the lungs. So there's new recommendations coming out for how to screen for that, but there's no baseline guidance. So there's no across the board way to screen and make sure that you're picking it up early. One of the things I think is probably most important is having women who have been affected by breast cancer not be exclusively fixated on their breasts, which I feel like happens when people are thinking about breast cancer. Even when we talk about breast cancer, we're fixated on the lump, we're fixated on finding the thing that's most publicized and looking for what the mammogram primarily detects, which is the mass in the breast, which is not even accounting for most of the breast cancer that occurs. So I think we fixate on the breasts, and particularly when we're diagnosed with cancer in that area, we tend to fixate on that area and not think about the rest of our body. So I think probably the most important thing is for a woman to be aware of any symptoms that she's having systemically and be really mindful of how her body's feeling. And if anything odd is happening, then see something, say something, feel something, say something, and be an advocate for yourself, because we do tend to overlook metastases in medicine, and in particular for breast cancer. It's one of the biggest things that's an issue right now, is figuring out how we can do a better job of detecting that metastatic disease and helping women find it themselves or be aware of the symptoms.
I'm glad that you said that, because I was, as you were discussing that, I was kind of thinking about when a woman gets diagnosed, I mean, anybody for any matter with any kind of cancer, but I know we're specifically kind of talking about breast cancer here. So when a woman gets diagnosed with breast cancer, and that's an overwhelming diagnosis for anyone, especially for anyone who is anything medicine is basically unknown to that person. You know, it's overwhelming and it's scary. And like you said, we tend to fixate on that one thing, like, oh my gosh, and our minds go crazy. What would you say as a provider of some ways that a woman could then advocate for herself, or maybe some instances where you've seen certain things get overlooked for a patient that, you know, maybe that patient or that oncologist or that surgeon or whoever it may be, you know, how can they advocate for themselves to ensure that they're accomplishing and getting done everything that is essentially medically necessary for them to make sure that, you know, everything else is being monitored as well, and that someone else isn't just fixating on the breast as well. So I'm not sure if that makes sense.
The likelihood is that because we silo things in medicine, the likelihood is that the oncologist is going to fixate on a particular kind of cancer that they're treating, and that's going to be kind of their realm as far as that patient's care. So the oncologist is probably not the person to be mindful of and monitoring for metastatic disease, although one could argue that they should be, and they should be involved in that process. I think that the most important thing is that the woman have a provider, and it doesn't necessarily have to be the oncologist, but she needs to have a provider who she can go to, who's going to hear her when she says, look, I'm worried about this and something's wrong, and who's going to put the puzzle pieces together, I think, to say, gosh, maybe this is related to your disease, and maybe it's not, like maybe it's completely unrelated, but to have the capacity to explore that and at least check the box saying, well, we looked and that's not what's going on. But I think the hardest thing is, in a lot of primary care settings, people are really limited in the amount of time that they're able to spend with their providers. And that's largely because providers are trying to get through the day and manage so many other things. And so a lot of times women end up, I have this concern, it's kind of a vague concern, it may be related to this, it may not be related to this, and there's a kind of continue to monitor approach. So the provider sees them and says, yeah, well, that's not really anything. I think that probably the best place for a woman, or the best thing for a woman to do to advocate for herself to ensure that she is getting the evaluation that she needs, is demand the time and space. And if it's not something that's being provided, look for a provider who's going to offer that, because it is invaluable. I think if we don't have the space to really articulate our concerns, if we have just a few minutes with the provider in the room and we have a concern that is maybe more vague, because metastatic disease does present as kind of weird symptoms, and there isn't like a picture of what metastatic cancer looks like. I think that we need to do a better job as a medical system as a whole, but I think that the best way that somebody could advocate for herself is to really find a provider that's going to
Advocate for her.
for her
Yeah.
and hear her
Yeah.
and be in a position. It's not the provider's fault if they
Right.
can't. It's just the system that they're working in. But I think to put herself in a position where she knows that the provider is going to engage with her and be able to hear her and see her perspective, like see where she's coming from relative to her disease process.
And really making sure, and I know we talked about this before, we talk about, insurance and whatnot very frequently about, provider looking at something and then passing it off to their staff. Essentially, that's the job of, hey, follow up on this, do the, whatever it may be. And things get lost in the shuffle. But really finding a provider who, like you said, is number one, going to advocate for that patient, but also know that the provider is going to be following through with everything that they would like to have that patient have done or do, or, following up with the patient and making sure the patient, isn't needing anything. Maybe they're afraid to say something, maybe they're uncomfortable saying something or whatever it may be, but having that provider really taking the initiative to, like you said, advocate for that patient as well.
Well, I think own it and own it in terms of having the accountability of being responsible for that person's outcome. And I think that that's something that's kind of gone by the wayside. I'm thinking about the conference that we attended this week and the discussion of independent practice versus large medical systems and what's happened to patient care as we move from independently owned and independently operated clinics to large medical systems where they have clinics who provide care for people. Is the provider is no longer owning the patient. They're no longer responsible. That's not their patient. It's a patient that belongs to the health system, and the health system is not a provider, right? The health system is a machine that's been put in place to kind of sort people through and see them in a systematic fashion, but people are not systematic beings, right? So if you had a concern, and let's say you were worried that you'd been diagnosed with breast cancer, you were worried that you had metastatic breast cancer, and you were having an odd tingling in your arm. Your evaluation is going to look completely different from somebody else who comes in having the same tingling in the arm. And when we make medicine a systematic process, we lose the art of evaluating the individual and all of the components that may be contributing to their symptoms and what we need to do to really assess those symptoms and get to a diagnosis. And a lot of that people just don't have time for anymore because the system allows a certain amount of time for each individual appointment. And once you're over that time, you have to make another appointment to come back.
Which is unfortunate, especially when you are presented with such a heavy diagnosis in any type of cancer, right? But again, specifically, we're talking about breast cancer. But when you're handed with that diagnosis, you need the time and space with a provider who knows what, different outcomes can look like, different treatment plans, sorts of different things. You need the time and space with that person to ensure you're getting your questions answered and you're getting your specific treatment plan, because your treatment plan is not going to look like her treatment plan. Even if you have been diagnosed with the same breast cancer, it's still going to be maybe right breast, left breast, maybe, different I can't think of the word, but though it's the same diagnosis, two completely different cases.
Yeah, and I think that we can probably extrapolate from that to any condition, right? Like, let's say you have depression. Your depression is going to respond differently to a medication than anybody else's depression. And I think, we really shouldn't put any kind of blanket treatment on all human beings because all human beings are different. So cancer is very much that way. We could have the same kind of cancer, exact same kind of cancer. You could receive the same chemotherapeutic agent and your cancer could advance. my cancer could go away receiving that chemotherapeutic agent. I might not need radiation, but then you might end up needing radiation or a different approach. You might end up needing surgical intervention. I might not. We might have the exact same disease, but it's manifesting and responding differently in our bodies. And that's such a complicated, multifactorial thing that I think, probably every condition is like that, but cancer in particular responds very differently from person to person to do the same treatment.
Yeah, and I know, sometimes when, and this is just from, talking to women in the past, when they say like, oh, you have this type of breast cancer and I have this type of breast cancer, and why did you only get a lumpectomy if I needed a mastectomy? Like, how come you got to keep your boobs, like, and I had to lose mine, though we have the same exact cancer? I mean, I shouldn't say exact, right, because it's obviously going to be a little bit different, but kind of perseverating on that of, well, what the heck, that's not fair. Like, how could you maybe advise those women, or how could you potentially have them walk through that process of her situation being different than your situation, and maybe your outcome was a little bit worse or worse off or more extreme, but mentally navigating through that is tough because you have your own mentality on, what maybe you wanted through the process, or what you thought might happen, or maybe what somebody told you was going to happen, and then once they got in there for maybe a potential lumpectomy, then they realized, shoot, maybe we should just do the whole mastectomy, and kind of emotionally walking through that.
A mastectomy versus the lumpectomy?
Yeah, and just, same cancer, different treatment.
Yeah, I think that's part of the complicated thing about support groups for particular kinds of conditions, or even, Facebook groups or any kind of social group where people are connecting who happen to have the same condition, whether it's breast cancer or another condition. You can see this on all kinds of forums. So any kind of medical forum you'll go on, you'll see that people are having different responses and different treatment approaches to similar conditions, and that some people might need a more invasive approach and some people might need a more modest approach. And I think what that ends up doing sometimes is having women question whether their treatment was right, like whether it was the right thing. And I think that the most important thing is, before they engage in any kind of intervention, really talking about the risks, the benefits, the alternatives, and what if I don't do this? Like, what would happen if I didn't engage in this intervention? So if I don't want a mastectomy and my provider is recommending that I have a mastectomy, I need to be asking the question, what happens if I choose not to do this? And I think so often, in particular with cancer, so often we're so worried it's going to be the thing that kills us, right? Like, nobody hears I have cancer without thinking I'm going to die from this. So I think that it's a heavy thing, and people are in a particularly vulnerable place when they receive a cancer diagnosis and they want it out of their body, right? Like, they want the thing that's going to get the cancer gone. And what we realized probably about 10 years ago is that when we do those radical mastectomies, sometimes it's a very good thing, and sometimes it spreads the cancer through people's bodies. So it's not always the best approach. And I think having a really candid conversation about what's the risk, what's the benefit, what does this look like for the rest of the life that I'm going to live, right? Provided that this cancer isn't what kills me, because everybody's going into it thinking it's going to be right, and I got to get it out, and I got to stop this thing. And then they come out the other side, and especially if it's a young woman diagnosed with cancer, they come out the other side still having decades of life left to live and being affected by whatever that treatment was. So whether it's somebody who was young and still in her childbearing years and wanted to have children or have more children and now cannot, or whether it was somebody who ended up with a radical mastectomy and now has significant scarring and is going to have to go through 6, 7, 8 surgeries just to have reconstruction of her breasts, or decide not to have reconstruction of her breasts and live for the rest of her life as a woman who doesn't have breasts. All of those things, I mean, it impacts any treatment that a woman's receiving. If she's a mother, is impacting how she's able to parent her child. Sometimes you end up with what's called thrombocytopenia, or not having enough white blood cells, and then you're having sickness, like you're getting sick, you're ending up, or not having enough platelets and you're having bloody noses, or you end up with leukopenia, which is not having enough white blood cells, and you're getting sick from your kid being sick, and you can't be around your kid without a mask on because your kid's carrying germs that can make you really sick. And I think what we forget sometimes when we think about cancer, because we think of it as like a death sentence, is that cancer is not necessarily a death sentence, and it's not necessarily going to be the thing that leads to your death. It might be, but most often now, especially with the advances that we have in medical treatment, most often people are getting their cancer treated and they're having a long course of treatment, and they're living for a long time with cancer, either with the cancer or with the cancer in remission, or with the fear that the cancer is going to come back. And I think one of the things that we have to think about when we think about treatment is having a conversation with that person about what this looks like, what the outcome looks like for the rest of their life if they choose to have that treatment, and what if they don't? And what's that outcome look like for them? And I think not having that conversation is doing a disservice to the patient, but also to everybody in her life, because she's going to have to live with the ramifications, and her family is going to have to live with the ramifications, and her friends are going to have to live with the ramifications, and everybody needs to know how to support her in that.
And at the end of the day, it needs to be her choice or his, but it needs to be that patient's choice, what treatment they choose, how they choose to go about treatment, who they see, who they incorporate in these decisions, and not feeling pressured by any one person to do one thing or another. And I know I was looking at the clock there, and I know we have to kind of wrap it up here. So I just wanted to, is there anything you felt that maybe we should have talked about that we didn't touch base on before we say toodaloo here? No? It's pretty good?
Yeah.
Okay. So if anybody has any questions or any comments or concerns or anything, call us.
I guess the one thing that I would say, is that with cancer, there's always inherent fear. So once somebody receives a cancer diagnosis, there's inherent fear. And like I said, people are, get it out of me. I want it out. I want whatever treatment is going to get this out of me and prevent me from dying. And I think that puts the patient, the individual who has that diagnosis, in an inherently vulnerable place, because they're not able then to make any kind of informed decision. All they're thinking about is what's going to happen if the cancer continues to be there, and are they going to die? And so they're coming at it from a place of fear, and it's incumbent then upon the provider to be exploring those things. And maybe it requires more of an interdisciplinary team, and having people talk about what this looks like to walk through it on the other side of the cancer. Like, when you're done with chemo, this is what it's going to be like. This is what going through chemo is going to look like for you. This is what radiation looks like. And for the rest of your life, this is how it impacts it. And for women who have an estrogen receptor dependent cancer, they need to be on medication to suppress that cancer from recurring or from attaching to those hormones, and that can impact things like they might never want to have sex again. And we think of that as like a superficial thing, right? But if somebody's living for decades and they have a partner who wants to engage sexually with them because that's a big part of their relationship, then that's going to impact their lives. And you want to treat the cancer and you want to be effective with it, but you also don't want to give somebody such a poor quality of life on the other side of it that they wish they hadn't lived through it. So I think that's kind of the fine balance, and that probably the most important thing is having that frank conversation. And the patients probably, you asked how people can advocate for themselves. I'm not sure that they can. So I think it really helps to have a support system of other human beings who can ask some of those questions and
help them navigate.
Yeah.
So if anybody has, I'm glad that she brought that up. So if anybody has any, maybe not just questions, if you are a woman and you are having some trouble navigating a road, maybe it's a breast lump, maybe it's breast cancer, maybe it's any sort of diagnosis. If you're having a hard time navigating that road and you don't feel like your provider maybe has your best interest or isn't hearing you or anything like that, please do not hesitate to give us a call. We are here for you guys. You know, we are dedicated to helping women, you know, figure out their best,
It's right for them.
yeah, their best treatments and whatnot. And if you do have any questions, any concerns, anything,
You can always call, you can always post them here. If you're watching after the fact, you can always shoot us a message and we'll answer your questions.
call us. I feel like a talk show host. See you guys later.